Hey guys, and welcome back to Confessions of a Doctorholic. If you're new here, my name is Hafsa and I'm a general surgery resident. And in this podcast, I share real stories from behind the scenes and inside the hospital. And today's story is about something that happens more often than people think. Patients leaving the hospital when they probably shouldn't have. So this was a patient who came in with a history of pancreatic cancer. Now, for anyone listening, pancreatic cancer is one of the more serious cancers because it's aggressive and the prognosis is typically very poor, even with treatment. This patient had actually undergone a Whipple about 15 years ago, which is a big surgery where parts of the pancreas and surrounding structures are removed and sometimes reconstructed. And the fact that he had lived several years after that was actually quite significant and a miracle, some would say. So he came in with symptoms of a bowel obstruction. So basically his intestines were not moving things through properly at all. He had abdominal pain, he was bloated, he was vomiting, he was unable to eat. And he came in partly because he's had enough and partly because his mum was forcing him. And when that happens, one of the first things we often do in the emergency department or on the floors or wherever is we put something called an NG tube. It's quick and easy as long as someone hasn't had an esophageal surgery. It really comes with minimal risk, just annoying in terms of like discomfort for the patient. But it's a really easygoing thing of you just shove this tube down someone's nose and into their stomach to relieve the pressure. Not fun for the patient, but super effective. So we go in to talk to him. And understandably, he's frustrated. He's been through a lot, cancer, surgery, treatment, and now this. But here's where things got complicated. Another team member from the emergency department had told him that surgery would definitely fix him. And he doesn't know the details, but surgery would definitely fix him. And from our perspective, that wasn't the case at all because his cancer had already metastasized. So that means it had already spread. And operating wouldn't fix that underlying problem. So now I was in this awkward position where I had to explain that. And I remember saying something along the lines of, I understand what you've been told, but based on where things are, surgery isn't something that would help you. And you can imagine, it's not an easy conversation because from his perspective and his mum's perspective, I felt like whenever family's involved, it's heaps worse because I'm not only removing hope from the patient themselves, and sometimes I would say patients know that, something really severe is going on. So sometimes they kind of have come to terms with it before their family members have. But for their family members, it's a huge struggle. And just like me getting into surgery for the fix-it, that's how many patients see the surgery team as well. So from their perspective, there was hope and then suddenly there wasn't. And I'll be honest with you guys, this was one of my biggest frustrations in medicine. When expectations are set in a way that's not accurate, because then you're working almost twice as hard to undo that and to rectify what the family thinks, and you're the person that's breaking their hearts. So we recommended an NG tube, supportive care, symptom management. He refused the NG tube, which was, again, understandable because he said it's uncomfortable and he had to go through it multiple times. I also had a really detailed discussion with this patient. So usually when a patient has a bowel obstruction from a malignant cause or from a tumor, what we do is we put a tube in directly from their stomach out through the skin. So you wouldn't see it coming out of their nose. It would be under their clothes, so you wouldn't necessarily know. But what they can do is from time to time open that up and drain stuff out, which would relieve the obstructive symptoms. So I was in the conversation with the family and I was essentially explaining that we're at a point in time where the cancer seems to have spread significantly and there isn't much to do. And there were outpatient oncology notes to support this as well, that he's kind of come towards the end of his line. So I was talking to him about this as a palliative measure. And understandably, him and his family were quite upset by that because no one likes hearing the word palliative. They like hearing that there will be a solution for their problem. And the mum kept repeating to me, she was like, I don't understand. I spoke to a doctor 5 minutes ago and they said surgery would fix it. And I had to be like, respectfully, ma'am, I'm from the general surgery team and I'm telling you there isn't anything more that we can do apart from giving him a venting gastrostomy tube. So when he came in, he was like super dehydrated because he felt unwell and wasn't drinking anything or eating anything because of that fear of getting nauseous and throwing everything up. So he got better with fluids. He felt slightly improved. And because he didn't like what I had to say, he was like, I don't really need to be in the hospital. I'm fine. I just got my little fixer-upper situation. And he left the hospital against medical advice. And this is the part where you kind of know this will not end well because that was just a temporary measure. We gave him fluids to perk him up and he left. Sure enough, next day he came right back. And this time he was worse. He was in more pain, there were more symptoms, and then we had that same conversation again. But I think when he came back, he probably had some more time to think about it. And oncology have seen my notes, so they were more involved and they were like, yeah, like what she's saying makes complete sense. And we explained the whole situation again, and he finally agreed to getting a gastrostomy tube to help relieve this pressure longer term until things are essentially done. So cases like this are super complicated because on one hand, patients have the right, they always have the right to make their own decisions, even if we don't agree with them. But as doctors, it's also so hard because it's our responsibility to guide them because we have that knowledge, that behind the scenes experience and information, and we've seen these cases before. So it's our job to set those realistic expectations. So I think the biggest takeaway from this case was how you communicate matters because one sentence can completely change how a patient understands the situation. And understandably, they want to hold on to any piece of light that they possibly can. And to be honest with you guys, there was a small part of me that thought I knew this would happen, but at the same time, it's not about being right. It's about getting the patient to a place where they understand what's happening. So, confession of the day. Sometimes the hardest part of medicine isn't the diagnosis, but it's getting everyone on the same page. So, I want to ask you guys something. If a doctor told you something different from another doctor, who do you trust? The first doctor, the second doctor, you'd get a third opinion, or you wouldn't know what to do. I'm curious to hear this, and I'm curious to know about your experiences with doctors. Alrighty, guys, thank you for listening, and I'll catch you next time.